Hello everyone. Welcome to the Cognitive Behavioral Insomnia Therapy for those with chronic pain webinar. We're glad you're here with us today. I hope you'll bear with me through the introduction. I have a bit of a cold right now, so my voice might sound a little froggy or a little stuffy. So my name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability. And this webinar is made possible through the support of the Community Gaming Grant through the BC government, as well as donations and memberships to CIRPD. As mentioned, my name is Tanya, and I'll be moderating the webinar and handling the Q&A session today. And our presenter is Dr. Colleen Carney. Dr. Carney is an associate professor and director of the Sleep and Depression Laboratory at Ryerson University in Toronto, Canada. She's the current president of the Association for Behavioral and Cognitive Therapies, Insomnia and Other Sleep Disorders Special Interest Group. Her research has received support from the National Institutes of Health, the Canadian Institute of Health Research, and Ministry of Research and Innovation. She trains students and mental health providers in cognitive behavioral therapy for insomnia at invited workshops and international conferences each year. She has numerous publications on the topic of insomnia and is a passionate advocate for improving treatment options for those with insomnia and other health problems such as chronic pain. Thank you very much for being with us today, Colleen. I know it's a hot topic and we have lots of people that are interested in what you have to say. So I will hand it over to you now.
All right, thank you so much. And thanks for inviting me. So today we're only going to spend an hour together, so I'm going to give you more or less an overview or maybe an introduction to cognitive behavioral insomnia therapy and some of the issues in people with chronic pain. I think it's a no-brainer that people understand that there's a relationship between pain and sleep. I do, however, think that some people have assumed that the relationship really only goes in one direction. That is that pain disrupts sleep. But certainly we know that sleep also disrupts pain. So we know that we can induce pain and it will disrupt sleep, and that's both in humans and animals. But we also observe many problems sleeping in people with pain. So we see not only sleep complaints, but when we look at the brainwave activity of people with pain conditions, we see a lot of sort of activity that we would normally see during wakefulness, and even when they are getting into the deeper stages of sleep, and there is less deep sleep in people with pain, we see an intrusion often of these sort of faster wave activity that we see mainly when people are awake. So even when they have deep sleep, it's disrupted. And interestingly, if we take people that have neither pain conditions or sleep conditions, and we deprive them of sleep experimentally, they will begin to report problems such as myalgia, so aches and pains, and their pain thresholds were changed, so their ability to tolerate pain the next day during pain paradigms is diminished. So we know that there's an important relationship here. In addition, the pain as it relates to being a condition or chronic pain condition is actually a fairly prevalent problem, as is insomnia. It probably would not shock you to hear that the overlap between chronic pain and insomnia is high, although you might not know that it's quite this high. It's somewhere between 50 and 88%. It's such a wide range because it depends how we define that, of course. So there is a huge overlap here, but what you may be surprised to hear is that there's a very large overlap between obstructive sleep apnea, a breathing-related disorder, and chronic pain. You can see that it's almost as high. Now, there are probably many different reasons why there is this overlap, some which may have to do with the pain itself. So with certain pain conditions, we may see very little movement, very little ability to engage in activity, and so we see some sedentary lifestyles. People who are sedentary are at high risk, obviously, for weight gain, and weight gain can be associated with sleep apnea. But importantly, some pain medications, things like muscle relaxants and morphine, and depending on what they are, they can increase breathing-related events during sleep, and so you are at higher risk. Also, some antidepressants that are used in certain chronic pain conditions also increase the risk for breathing-related events, and so your risk for sleep apnea becomes increased. And sleep apnea is a silent killer. It's a disease that will kill you eventually. So it's something that's really, really, really important to screen for in chronic pain clinics. So one thing that we always want to communicate when we're talking to people who work in the area of pain is to assess for the signs of OSA, or obstructive sleep apnea. So one of the first things we look for are signs of daytime sleepiness. So if somebody is falling asleep involuntarily during the day, or they absolutely need to nap, and it's not related to their medication, then that's a sign for us that there might be something else going on, like sleep apnea. And we like them refer to a sleep study. I'm going to give you a quick little screener here, a little guideline to use when thinking about sleep apnea. We call it the stop bang. The first 4 questions of the stop are, do you snore? And really what we're asking here is, do you snore loudly and persistently? Could I hear your snoring through a closed door? Is it as loud as a conversation? The answer is yes, then you have 1 point here. Just because you snore doesn't mean you have sleep apnea, so it's just 1 point now. The second one is, do you feel tired, fatigued, or sleepy during the day? Now, I never like this one because most adults feel tired. It's not about being tired, it's actually about sleepiness. So do you have to fight off falling asleep, and do you lose that battle quite often? So if you're sitting in a car, you know, at a stop sign, could you find yourself dozing off? Things like that, that's unusual and it's significant. And if you are sleepy, then that's cause for a sleep study. The third one is, has anyone ever seen you, observed you to stop breathing in your sleep? Has they ever observed you to have an apnea? And the fourth one is, do you have high blood pressure? So this is typically the first of many different conditions that apnea is going to cause. So high blood pressure is definitely one of them. If you've said yes to 2 or more, or one of your patients have said yes to 2 or more, they should be referred to a sleep clinic. They may not get an overnight study because the sleep clinic may determine that there's not enough risk there, but it's worth an evaluation. The other 4 of the is actually the bang of the stop bang are really about risk factors. Do they have any of these 4 risk factors? So, is there a body mass index? Are they in the significantly overweight range? Are they older than 50 years old? Is their neck size greater than 40 centimeters? So do they have a thick neck? Are they carrying weight in their neck? And are they male? Now, I never like the male one. I don't like a lot of these of the bang, because what we're finding is that people who are average weight or women are not getting referred for sleep studies. So these are just risk factors, and they're associated with an increased risk for apnea. And if you have 3 or more on the stop bang, then we recommend that you go get a sleep study. If it's found that you have sleep apnea, then obviously what we would want treatment providers to do is to really make sure that people understand that this is not a sleep aid, the mask, that it is an aid to save your life, essentially, to restore breathing during sleep. And this should be helpful from a pain perspective as well. Now, in addition to obstructive sleep apnea, we also have to screen for insomnia. Insomnia is a disorder in which you have difficulty falling asleep or staying asleep, or both. If the pain is acute, so something like you have broken a bone or you just had surgery, and you have what we call acute pain that's assumed to, it will resolve itself shortly, then one of the things that we recommend is that that you engage in pain management, which often is pain medication when it's acute. and that you consider using an approved sleep medication along with it just to help you. So for example, if you've just broken your leg and you've got this big bulky cast and you're not able to sleep, maybe it would be a good idea to go on a sleep medication just during that time until the acute pain is resolved. If, however, you have chronic pain is a little bit different. For example, it goes on for a longer period, and people with chronic pain have a different sleep complaint typically. So with acute pain, it may stop them from falling asleep and prevent them from falling asleep, rather. When it's chronic pain, often people can eventually fall asleep, but the quality of their sleep is greatly impaired, and they may have wake-ups here and there. And so we usually have a different sleep strategy. So in addition to the pain management, the frontline treatment that is supposed to be recommended for somebody with chronic pain is something called cognitive behavior therapy for insomnia, or CBTI. Now you may wonder, why CBTI for chronic pain? Why wouldn't you use sleep medications or something else? Well, I don't want to get too technical, but one thing to consider is that when you test sleep medications against cognitive behavior therapy, the effects, how effective they are essentially the same. So they are equally as effective. But CBT is a more durable treatment than sleep medication. So that what we mean by that is that people are sleeping well months and years after they've stopped the therapy. It's a very brief therapy. It's usually somewhere between 4 to 6 sessions, 1 hour each. And when you think about that, if you do 4 sessions of this treatment, and 3 years later we assess you and you're still sleeping well, that is a much greater response than taking a sleep medication, and then when you stop taking the sleep medication, your sleep problem returns. So this is why we recommend it. Also, people with pain conditions may be on multiple medications, and we often don't want these medications mixed. And so it's a safer bet to use CBT. And interestingly, there's been many different trials where we've tested CBT for insomnia in people with pain, and we find that the effects that we get in people with pain are really the same as we get in people without pain that just have insomnia only. And again, the effects are durable even a year out from having that trial of CBT. So we do know it to be very effective. So I want to give you a little model of what CBT is, and the way that I can best describe it is to explain the factors that cause insomnia. So down here in the yellow, we see some predisposing factors. Now, predisposing factors are factors that increase your risk for having insomnia. Oh, I don't know if I did that. Let's get rid of that. Factors that increase your risk for insomnia. And let's just say if you have a tendency to worry. You can see that if you are somewhat of a worrier, your sleep may get worse and better over time, but you're still well below this line that tells us whether or not you're going to have the disorder itself, the insomnia disorder. So that alone is not going to cause insomnia. What you really need is the blue, which is a precipitant. And a precipitant would be something like, I've got a big talk tomorrow, so I'm nervous, right? So in anticipation of this big talk, I'm now feeling really anxious, and I have this tendency to worry, and now my sleep is disrupted, right? We never sleep very well when we think there's an emergency, even though a big talk tomorrow is probably not really an emergency. So you can see here we've crossed over the threshold for having significant insomnia, but as soon as that big talk occurs, we really should go back to sleeping well, and it should go back below this line, right? And for most people, that's what's going to happen, unless we have some factors right here that are denoted in the red, and these are perpetuating factors. Perpetuating factors are factors associated with coping with that initial sleep loss, right? Because right here we have bad sleep. So what are the things that people do to cope with bad sleep? Well, these are just some examples. One is that most people will try to go to bed a little early. Again, not really a big deal, but we'll learn in a moment how that can disrupt your sleep. They might have a glass of wine. And, I'm really nervous about this talk. I need something to take the edge off. I'm going to have a glass of wine, or smoke marijuana, or whatever it is that you're going to do. After, you can see this is several nights, so after a few nights you might start to worry, oh my gosh, what's going on? Is this going to be a chronic problem? And you start to become preoccupied about sleep or fatigue. You may try to sleep in the morning to make up for lost sleep, or you might try to nap. And the thing that's important to note is that all of these behaviors actually have a negative impact or a negative effect on the sleep system, which we'll talk about in a moment. And so the perpetuating factors in a chronic insomnia are what's important. We may never know what initially caused the insomnia. It may have just been merely pain, right? So the pain itself was the initial cause of the sleep problem. But what's really important is that once the pain resolves, if it's acute pain, then we would expect sleep to go back to normal. But if it doesn't, then often we see that there are perpetuating factors that have taken over and are now what we need to target. So what are the key perpetuating factors for insomnia? There are three main ones. One is having a low drive for deep sleep. This is particularly important for pain, as we'll learn. Having weak input into the circadian system, or our body clock, or having an overactive arousal system. So let me talk about this deep sleep. So from the moment we wake up in the morning, this is a very technical slide, we start to build a drive for deep sleep over the course of the day. In technical terms, we're building up a chemical in our brain that's a byproduct of our cells working, and it builds and builds and builds in our brain until we get sleepier and sleepier at the end of the day, at night, and then we go to sleep. Okay? Now, interestingly, that drive for deep sleep is associated with how much growth hormone you will get released during that night, and that's really important because growth hormone is the thing that restores tissues. And if you do not have growth hormone release, you'll have an increase in pain. So you can see that the relationship between deep sleep and pain relief and pain thresholds, there's this very tight relationship here. Okay. So if we need to build a drive for deep sleep in order to have this good quality sleep, then there's going to be some behaviors that could have a negative impact on that buildup. And they are spending an increased amount of time in bed. And this is particularly relative to how much sleep you can currently produce. So if you're somebody who can only produce 6 hours right now, and you're spending 9 hours in bed to make sure that you cast this big wide net, make sure that you get sleep when you can, then it means that you're going to have less deep sleep. Certainly napping, sleeping in, going to bed early, these are all behaviors that are actually going to make things worse. And decreased activity will, because remember I said that deep sleep drive is built up by chemicals working, sorry, not chemicals rather, by our cells working. And so when we are not able to be as active, it means that we have less drive for deep sleep and then less growth hormone secreted during the night. And the fact is that many pain patients often have to rest. Okay, so let me show you in a different way. If you normally get up around 7 and then you try to wake up a little bit later because you had a really bad night's sleep, then when you go to bed at your habitual time out here, you can see you have a shortened amount of time and an insufficient drive for deep sleep. And that works whether you're sleeping in during this time or not, because for some people they'll still wake up at 7 but they'll lie in bed trying to produce more sleep. And the effect is negative no matter what. Likewise, if you're somebody who does get up at 7 a.m., but you want to have a nap in the afternoon, there's actually nothing wrong with naps, except we know that it has a negative impact on the growth hormone and the deep sleep that you'll get that night. And so for somebody with pain, this is a real no-no, because we need them to get a lot more of this growth hormone in order to help them with their, not only their sleep, but also their pain. So when you nap, essentially what's happening is you have built up some drive for deep sleep by being out of bed at 7 a.m. But as soon as you nap, you burn off whatever you have built up. And so then you essentially have to start almost from zero again, and it just simply is not enough time by the time you're ready to go to bed that night. And so you may sleep the same amount of time, but the quality of sleep will be impaired. One last example of how these issues can kind of creep into the picture. This is somebody who told me, oh, I spend 8 hours in bed every night. I'm very, very consistent. And I said, well, let's just track this on a sleep diary to see if that's true. And you can see that they sort of go to bed around 11, and they sort of get out of bed around 7. So I can see how they would think that they spend about 8 hours in bed. But you can see that by Thursday, they've gone to bed a little bit earlier, right at 10:30, and the alarm went off at 7. But after a couple of hits on the snooze bar, they actually got out of bed at 7:25. So now we're looking at about 9 hours in bed this night. And by Saturday, they go to bed around midnight, so a little bit later, but even though they woke up at 8:40, they're still in bed at 10:50. This is about 10 hours in bed, and Sunday is 12 hours in bed. So 12 hours in bed, think of it in a reverse way. It means that you have less than 12 hours to build the drive that you need for deep sleep and for that restorative sleep that you need. And adults simply cannot produce 12 hours of sleep on a night-to-night basis, right? So this is something that we would see more, we would want for a toddler who can produce that amount of sleep. If you can't produce that amount of sleep, then automatically you're going to deprive yourself of deep sleep. The second factor is that the clock is not reset daily. The thing is that our clock inside of our body is longer than the 24 hours that we have on our clock. And so there's a little bit of drift there. So we have to set that clock every day. If we don't set that clock with regular behaviors and regular exposure to things that help set that clock, then we're going to experience drift. So if we get into bed and get out of bed variably, right, and this is particularly important for getting out of bed, then we're going to experience some drift in the clock, and the clock is not going to be running very smoothly. Also, it limits our exposure to natural light, things like sunlight, which is very, very, very important for the clock. Now, one way to think about this is to think about if you've ever had jet lag. So if you think about the symptoms you get when you have jet lag, it's things like fatigue and difficulty sleeping and some mood problems and some concentration problems. These are the same types of symptoms that you get with insomnia. And the reason why you do is because jet lag is nothing except the mismatch between the clock on the wall and the clock local time. So I think I have a demonstration. Let's see. I do. Okay, here we go. So let's look at this one example. And you can see this person thinks they're very regular. So they say, oh, I get into bed around 11 and I get up at 6 every morning. And you can see they're really not that regular in terms of when they go to bed, but they do set an alarm all during the week. So that's probably where some of their belief that they're regular. Now this is the time they actually get to bed. So we know that this person probably has a snooze bar. Because they are laying in a good hour or so past their alarm time. Now, if you look between Saturday and Sunday, if they're going to bed roughly around 11 o'clock most nights, you can see that on Saturday they're going to bed a good 3 hours later, and so their body expects them to go to bed at a certain time, but they're going to bed much later. So, and then on Sunday, and this is what most of us do, so Saturday night we stay out late, but Sunday we go to bed early because we're trying to get back on track for our workday on Monday, you can see there's a 4-hour difference here. A 4-hour difference is like traveling from BC to Newfoundland. And so, and you wouldn't expect to be able to make that trip, sort of a New York to LA trip, without having physical symptoms like difficulty sleeping and feeling tired during the day. But we do this all the time, and we blame it on poor Monday, but it's actually jet lag that we're creating. Same thing with the rise time. During the week, it's usually around 7 they get up, but look, on Sunday they get up around almost noon. That's a trip to Europe. It's almost 5 hours, right? So this is something that we want to try and reset in people with pain. And the third factor is having an overactive arousal system. So the arousal system is important because we want it to be able to keep us awake when there's danger, right? So if somebody's breaking into our house, we wouldn't want to say, well, you know, I've got this great drive for deep sleep going on right now, and it's perfect time in my clock, so I'm just going to go to sleep and hopefully nothing bad will happen. No, we want us to be able to inhibit sleep and to respond, to escape, or whatever we have to do. But sometimes the system in insomnia has become overactive and over-aroused. So one of the ways that we can determine if this has happened, if we listen for a very particular type of story. So I call it the switch story. And the switch story goes something like this. Somebody says, I was so tired. I was falling asleep on the couch. I thought, this is the night. I'm ready to go. And I went upstairs, and I got in my bed, and bang, it was like a switch went off, and I was wide awake. When people tell us the story of being suddenly wide awake as soon as they hit that bed, we know that there's something called conditioned arousal. What does this mean? Well, let's go back to thinking about what you learned in psychology if you ever took a course in university. Okay, so essentially, if you show meat powder to a dog, they're going to drool. You don't have to do anything. They don't have to learn anything, right? So that's just a natural response they're going to have. But if you pair the meat with a bell over and over and over and over again, then interestingly, over time, you can present the bell, ring the bell, don't show the meat, and the dog will drool. Why? Because it's created an association, it is learned as an association between the bell and meat. If you pair the bed over and over and over again with wakefulness, then you are going to have wakefulness, and this is how you get conditioned arousal. So think about with pain. If somebody wakes up and they're in, especially if they're in distress, and that happens in the bed, and they're wide awake and distressed, and this gets paired over and over again with the bed, you can imagine how this would elicit wakefulness. So if you experience wakefulness in the bed repeatedly, then it's going to increase the likelihood that you're going to be awake in bed subsequently. In addition to conditioned arousal, you want your bed to equal sleep. But if you do things in the bed that are not sleeping and are actually wakeful activities, like eating, being on the computer, whatever it is you're doing, then increase wakefulness in bed. Now, if you can imagine somebody with a pain condition in which they may spend considerable time in their bed, right, that there may become a pairing of the bed with wakefulness. So unbeknownst to them, this is what's happened. And one last fact about arousal. We know that medications can have negative effects on sleep. It is highly variable. When we do studies, it's not a reliable finding that we see. So I will just go over a few of these, but all I really wanted you to see is that some of the medications that are used in chronic pain conditions can either increase light sleep, sometimes they decrease it. In most cases, they decrease deep sleep. In some cases, they increase it, although not reliably. And in some cases, they decrease rapid eye movement sleep. In some cases, they increase it. So we never kind of know what's going to happen when somebody takes a medication, and it could be sleep disruptive. And of course, I talked to you earlier that certain medications, like the opioids, can increase breathing related events. So certainly doctors need to be looking at whether or not some of the medications may be playing a role here. Okay, so let's summarize. So sleep is controlled by a clock, a circadian system, and it determines when it's best for us to sleep. And problems can arise if there's instability, so not enough steady input into that clock, so a variable schedule, for example, or a lot of time inside so that you don't get exposure to regular light. Sleep is also controlled by a sleep drive mechanism that controls how much deep sleep we get and how much essentially pain relief we get. And we need to build it up over a 24-hour period, but usually we're only awake for a certain amount of hours in order for that to accumulate. And if we don't build up enough of the deep sleep drive, because we're inactive or we spend too little time out of bed or whatever, then we're going to have problems with the depth of our sleep. And lastly, sleep is controlled by an arousal system, and it's very helpful that it can override sleep during emergencies, but sometimes the arousal system is overactive in situations with insomnia, so we get conditioned arousal or that switch story. Pain itself can be arousing, medications, concern or worry about whatever illness may relate to the pain condition, and often some people have a preoccupation with sleep or fatigue that they're actually very averse and afraid of wakefulness or afraid of fatigue, in which case things become worse. So let me just do one last little conceptualization here to see the relationship, and then let's get into how we treat it. So with chronic pain comes chronic pain symptoms, of course, and people cope with that pain in a variety of different reasons. But some of the coping behaviors that people need to engage in to cope with their pain, like, let's just take one example, rest. Rest increases the likelihood or the risk for dozing off. So if somebody has to rest because they're in pain, then they may run the risk of falling asleep during the day. And remember my diagram with the napping, then they're going to be at risk then, unfortunately, for having less deep sleep, and then they're going to have more pain, right? So resting has a negative impact on sleep systems, right, like the low drive, and it now has increased your risk for a chronic insomnia developing. And when the chronic insomnia develops, it often worsens pain, and people have to engage in more coping behaviors for the pain, including maybe taking medications that may be sleep disruptive. And certainly we know chronic insomnia worsens pain symptoms mainly by the decreased growth hormone. Moreover, people have to engage in even more behaviors like resting, and when we rest for long periods of time, then there's a risk of secondary pain, right? So muscle shortening and deconditioning and so on, which can make the pain worse. You can see how difficult this is for somebody with pain. It's like a trap. And so you have to be very creative in finding ways to help them. So what are some ways that we can help? Well, CBT came out of research that studied what caused insomnia and what perpetuates insomnia, essentially. And we came up with some ways of treating those perpetuating factors. And once they were found to be effective, then we packaged them together. There are two main components for CBT, which are stimulus control and sleep restriction, which we really don't call sleep restriction anymore because we don't actually restrict sleep, we restrict time in bed. So often you might hear it as like sleep efficiency training. Either of these two treatments can be used on their own, but they usually are packaged together. And many different versions of CBT also have what we call counter-arousal methods, so other things added onto these two treatment components. So what is stimulus control? Well, if it's true that the bed and wakefulness have been paired over and over again, what we want to do is we want to unpair them. We want to unlearn that association by being in bed only when asleep or pretty close to it. How do you do that? Well, first of all, we're going to have to explain the idea of conditioning, because I think it's strange to people, the idea of how this association happened. And it happened outside of someone's awareness, right? Just almost like with the dog, with pairing something over and over again. Once they understand how that works, then we can give them some rules and help them find a way to be able to follow them. So the first one is to only go to bed when sleepy. And sleepy does not mean tired. Sleepy means that you are fighting, falling asleep, and sort of losing the battle, right? So your eyes are rolling back in your head. You suddenly find yourself like sort of doing the head nod. These are signs that you are sleepy. Most people with insomnia go to bed before they feel sleepy. They go to bed when they feel tired, and that's why they lay awake. So we want people to stay out of bed until they're really, really, really sleepy. And number two is, if they get into bed and the switch happens and they're suddenly wide awake, that they are to get out of bed when they're not unable to sleep. And the reason why you want to do that is you don't want to pair the bed with being awake. So if you find yourself either in a lot of pain, get up out of bed and to go to a secondary resting place, or if you find yourself awake, you need to go to another place. For some people, it may not be safe for them to get out of bed in the middle of the night. They may have medications or mobility problems that make us nervous about them getting up in the middle of the night for safety reasons. If that's the case, we can use something called counter control, where they merely give up the effort to sleep. They sit up. We do allow them to do something, whether they're reading or watching television. I know that sounds crazy because we just said we don't want to pair the bed with wakefulness. But what we really don't want to do is we don't want to pair the bed with feeling distressed and attempting to sleep. When you are trying to fall asleep, it's the opposite orientation of what we want. Falling asleep is like falling in love. It's not something that you can make happen. And if you increase your efforts to make it happen, it's going to be counterproductive, right? Okay, so we want them to get out of bed when they can't sleep and only return when they feel sleepy again. This might happen a couple of times before they can actually fall asleep. No matter how they slept the night before, we want them to get out of bed at a consistent time every single morning. And the reason why we say that is that it's going to provide input into the clock, but it will also, if you've had a really, really bad night, it will give you the benefit of that you have built up drive for deep sleep if you get up at that time. And so you're more likely to get deep sleep that night, and which is what we really want for people with pain. For some people, the transition is very difficult. They might be very tired and in pain. So often they might not be able to start their day in an active way. So we might get them to get out of bed and go to a secondary transition place, which may be a comfortable, not necessarily a bed, but another comfortable place where they can rest, but they're still upright and they've gotten out of bed. We want people to use the bed in the bedroom only for sleep. Sex may be an exception to this rule if you're somebody that doesn't feel more alert after sex. And we want people to rest in places other than their bed, so a secondary resting place. And we don't want people to ever take a daytime nap while they have insomnia. And if they're resting, we want them to rest in a way that would make it unlikely they would doze off. So usually sitting up would be a good idea, for example. People who are in acute pain often have to rest. It's part of the medical plan for bed rest. So if that's the case, then we set aside sleep goals and we deal with the acute pain first. That's usually what we do. But so when rest is needed, people need to rest. But for most people, especially people with chronic pain, the treatment plan is often to increase people's activity in a safe way, a very gradual way, pace activity and scheduled breaks. And the nice thing is that treatment actually complements sleep treatments. It helps with fatigue. So resting actually makes people feel more fatigued when you have a chronic condition like this. So getting people to be active but in a manageable way can help with both pain, building deep sleep drive, and fatigue. And working with people to make sure they don't overdo it, though, because sometimes when people get a little bit of energy, they will overextend, and then they really pay for it. There's a lot of pain and a lot of fatigue. And so we do want to allow people to rest and maybe even schedule rest, but we want it to happen in a place other than the bed. And if medically acceptable, then we don't really want them lying on their back. For some people that is not possible, but for most people that is. The second part of the treatment is to try and build up a drive for deep sleep, and the way that we do that is to limit the time in bed to how much time they're currently sleeping. So we ask them to keep a sleep diary for 2 weeks and calculate how much sleep they're producing, their total sleep time, and then say it's 6 hours. Then we're going to ask them over the next 2 weeks to limit their time in bed to that amount, but then also add 30 minutes to it. We add 30 minutes because it takes up to 30 minutes to fall asleep, so we just want to add that. In doing so, it greatly increases the drive for deep sleep, and so people become very, very, very sleepy very quickly, and suddenly they're going to start filling up that time and getting deep sleep. So they should start feeling a little better during the day. As soon as that happens, then we're going to start increasing the time in bed in 15 or 30-minute increments per week. Right? So if they, at 6.5 hours in bed, are sleeping, a good, 90% of the time, and they're not having difficulty sleeping any longer, then we're going to extend that time in bed. All right, so let's just summarize. We ask people to get up out of bed at the same time every day, and we usually decide on that together. So if, for example, we've calculated that they're supposed to be in bed 7 hours during the next 2 weeks, then we might say, well, what's the time that you normally have to get up during the week? And they might say, oh, 7. So then we would say, all right, well then for the next 14 days, we want you to get up at 7, even the weekends, and go to bed only when you're sleepy, but never before midnight, because midnight would be 7 hours, right? 12 to 7. If you do get into bed and that switch happens, we need you to get up out of bed. And again, with mobility problems, that might not be possible. You might have to do something different. And don't return until you're sleepy again. We ask people not to do anything other than essentially sleeping while they're in bed, and to avoid napping. And I put this on a slide that says 1 session CBT because there is some evidence that we can do all this in 1 session and people's sleep can improve. Now you may have heard about sleep hygiene. Sleep hygiene can be part of the CBTI treatment. It is not an important part of the treatment. We don't always use it. And unfortunately, people think that this is what CBTI is. Sleep hygiene is actually about reducing caffeine and trying not to smoke and exercising but not right before bed if it's vigorous, and maybe having a lifetime bedtime snack and not having alcohol or marijuana right before bed. Not engaging in brightly lit or noisy conditions right before bed. But the thing is that all of these things, if you do them, they will not get rid of the insomnia, right? So it is not a supported treatment. On its own, it does not work. And probably many of your patients have found this. It does help people to improve their sleep if they're good sleepers. And these may be things that might be interfering with sleep. So, for example, if you're drinking lots of caffeine, it is true that that actually blocks the chemical that's related to deep sleep. So your sleep may not be as deep. So decreasing it won't fix your sleep problem, but it may lead to some deeper sleep. So these are things that we might review with somebody if they have a problem in one of these categories. Now, if somebody has something like cognitive arousal, I'm going to actually demonstrate this. You know somebody has cognitive arousal if this seems familiar to them. Okay, this is cognitive arousal jeopardy, and the categories are ways in which people have wronged me, strange noises, diseases I probably have, my endless money troubles, why did I say or do that? Ideas for a screenplay. Right? These are not particularly conducive to insomnia, to sleeping. And when people are complaining that they are having these active thoughts throughout the night, then we might engage in something called counter-arousal. Counter-arousal, there's a couple of different ways to do it, but one is to create a buffer zone. So we ask people an hour or so before bed to set aside some time which they wind down and sort of relax and disengage from goal-directed activity. We may ask them to engage in a relaxation practice. It doesn't really matter what they engage in, as long as it's something that they're comfortable doing. We might actually get them to do that practice. The best treatment for overactive thoughts is actually to get out of bed when it happens. It will train your brain to stop doing it, and it will create a little bit of sleep deprivation so that the next night you've built up a little bit of debt so that you will be more likely to have deep sleep. Okay, so just a summary. Obviously, we do need adequate pain relief. Unfortunately, sometimes people refrain from using pain medication if it doesn't get rid of all of the pain, right? So if their pain goes from an 80 to a 60, then they may not see the need to take the pain medication. But pain medication can have a positive impact, depending on what it is, on sleep, right? So we do want people to be managing sleep. If they're engaging in a pain management treatment, then this is also extremely helpful, and it actually complements what we're going to be doing as well. At the same time, there are some medications that can actually make sleep worse, and sometimes we can't predict whether or not a particular patient is going to have that kind of reaction. Also, some medications have sleepy side effects, which can create some problems in using CBTI. The types of sleep problems that we see again and again in people with pain are having a low drive for deep sleep. And a low drive for deep sleep is a big problem because they're not going to get the growth hormone that they want during the night that will help restore tissues and help bring down their pain thresholds and actually make them feel a little better and get rid of some of the aches and pains. One of the primary ways that we have low sleep drive is usually increased resting and increased time in bed, too much time in bed in the 24-hour period. So we can address that with CBTI. We often see a lot of poor input into the clock because of a variable schedule. People usually do this, to be honest, because they're exhausted, right? So there's laying in the morning, hoping that, that they'll get a little bit more sleep, or just they feel so tired they can't face the day. Hyperarousal, including conditioned arousal. This happens very frequently in people with pain because there often has to be increased resting, and so people are doing it in the bed, and so their bed has become associated with the place where pain occurs and where insomnia occurs, and that's something we need to break. Lastly, we see a lot of inactivity, and one of the reasons why we see inactivity is certainly pain, but we can see inactivity also because of poor sleep and fatigue. Unfortunately, being less active increases fatigue. It can create deconditioning and actually make pain worse, but it certainly limits the amount of deep sleep that you're able to get. And I think I will finish there because I think we have some time for some questions.
Wonderful. Thank you very much for that, Colleen. Very informative and a lot of information that I had not heard framed in that way, and that makes a lot of sense. That was very good. Let's see. We had one question. Do you have any data or information on using medical marijuana for insomnia/pain management?
Well, I definitely don't know. I don't know about pain at all. And I don't know about medical marijuana and insomnia. I know that marijuana makes sleep worse, contrary to people's beliefs that it actually improves. It's possible that medical marijuana may have different properties. I doubt it. One of the reasons why is similar to how alcohol works. So essentially when there's a chemical on board that your body then has to try to eliminate while you're trying to sleep, it disrupts the architecture of sleep. So typically what happens is that REM sleep, rapid eye movement sleep, is suppressed and moved to later in the night, and then it rebounds and it comes back with a bit of a vengeance. And when it does, your sleep is going to be lighter because REM sleep is light. It also makes you more prone to having bad dreams or weird dreams or vivid dreams. And so again, that is another way that it can actually be disruptive. So I think I'm going to hold off on saying anything about medical marijuana until we have good studies about it, but it is part of our sleep hygiene right now that we do ask people not to use marijuana. In this particular population where people may be using it for pain, it would be interesting to look at it, because if it does have a positive impact on pain, would that be enough to sort of say, well, let's not target it in the insomnia, like in sleep hygiene, because maybe the fact that they have better pain relief may lead to better sleep. So I think those are still unanswered questions right now.
Great. Someone asking, can you relate sleep with menopause and chronic pain when hot flashes, say, come every hour and it's impossible to get into a deep sleep?
Yeah. Well, menopause does not impair your ability to get into deep sleep, even if they're coming every hour, hot flashes, because that recovery system can't allow you to get back into deep sleep. But as you can imagine, and in fact, I used that same graphic that you saw about experiencing pain. That's actually my menopause slide, and it's because if you can imagine suddenly being roused out of sleep in the middle of a hot flash is really perceived initially as an emergency, and because of the vascular systems that are involved. And so people, it is highly arousing, and you wake up, and in addition to it sometimes being difficult to settle emotionally because it is extremely frustrating, there may be other matters to take care of, like even changing sheets, changing pajamas, things like that are actually really disruptive and kind of make you more alert. And if you're in pain, getting up to do those things may be actually quite difficult as well. So we treat menopause the same way we treat everything else, which is with stimulus control. So trying to teach people some coping when it does happen, because the easier they can settle so that they can resume sleep again rather than being what most people are, which is really frustrated. So we want people to try and settle back down again so that they can reinitiate sleep.
All right. Someone else asking, they say that they regularly read in bed and have for a long time because that eventually leads to sleep, but wondering would it be a better practice to read somewhere else and then go to bed once actually sleepy?
That's a great question. I would say it depends. So if you're somebody that has insomnia, then yes, that's a great suggestion. We would ask you to move that just to a different place, because reading before bed is a wonderful sort of buffer zone activity, and we want people to do that. If you do not have insomnia, and this is part of your relaxation, there's some evidence that good sleepers that reading in bed is paired with sleep. So meaning that becomes a symbol for them of sleeping, and so they read very briefly in bed because they associate it with sleeping, and so as soon as they start reading, they feel sleepy, and then they can go to sleep. If you're that person, then I would say that a lot of these rules don't apply to you, and it's probably fine. Reading in bed, doing anything wakeful in bed, does increase your risk of developing insomnia.
All right. And someone else asking, what type or kind of professionals are trained in CBTI?
That's a great question. There are a number of people who can be trained. We have done many studies, and interestingly, a lot of the pain studies that we have that have been conducted used people other than psychologists. So psychologists traditionally have been the people who have been providing cognitive behavior therapy. But out of acknowledgement that we wouldn't be able to reach enough people if we just kept it within that discipline, people started doing studies where they would train nurses, for example, or people without mental health backgrounds, because a lot of what we're doing here has more to do with math and information than it does really about getting into any sort of deep issues. So there is very good evidence that people other than psychologists and those people who have who are specialists in behavioral medicine can do this. That's something that I do. I go around and I go into family care practices and pain practices, and I train every single member of that team. You know, for physicians, I might do the one-session CBTI, so that because they don't have enough time to really go into anything deeper. But for the social workers that might have more access and more sessions available, then I might do a full version. And what's really important is that there's quite a bit of evidence that self-help, meaning that you're getting a good self-help book, but you want to get one that's actually CBT, would be helpful for many people. And some online CBT treatments would be helpful as well.
And so would that mean that it doesn't necessarily have to be a CBT for insomnia per se focused program, but even that just taking like the CBT online courses would be helpful in and of themselves?
Yeah, I mean, I think for some people they might need more. So I sort of think of it like a pyramid, and I think that, you know, at the broad base of the pyramid are most people, and something like, you know, picking up a self-help book, particularly one that is also geared towards pain would be nice, but it doesn't have to be, or an online treatment would be nice. If that doesn't work, then you know, maybe if you find a provider who seems like they might be able to do it, then that would be another good idea. But if you really have pretty severe problems, you might need to see a specialist, in which case you know, you might want to find somebody who's more sort of in my area of behavioral sleep medicine, where I just know a lot more about sleep and ways to tailor it. But I think that that's very few people that actually need someone like me.
All right. What do you think about the effect of screens on interfering with going to sleep?
I think that there's this is a new area, and so far it's really been tested in young males mainly. And in young people are photosensitive. So it's part of maturity. As we age, I'm going to throw myself under this bus, our eyes change and we become less and less photosensitive. And there's not a tremendous amount of data to suggest that we would really be sensitive at all to screen time. Certainly, if somebody was getting a ton of blue light exposure, which some devices have, it could be alerting. It could be. But that's not something that we worry too much about, except for our young adults. And as part of the buffer zone, if people are doing something like reading on a screen or whatever, and they find themselves becoming more alert, then we might recommend there are certain things you can download that will take the blue light out of the screen, you know, things like f.lux, or just programs that just change it to a red light. Unfortunately, people are very sort of fixated on things like screen time and lights, and they're not focusing on the things that actually cause insomnia. So we are not seeing some sort of increase in light-based insomnias. That we just aren't. And most people say, oh, and now I'm not doing my device, and so now everything's fine. And I'll say, but why are you here? If getting rid of the device was what was so important, then why is your insomnia still here? People need to understand that it's really about having a regular schedule and some good habits, and the light part of it may or may not be important, except certainly I would want kids and teens and even young adults to be limiting their screen time right before bed, because that is that effect is definitely something we've demonstrated.
Very interesting. I didn't know that. That's very good information. So we are like a little bit over time. So I do have some further questions. Would it be all right if I emailed those to you for answering, and then I can distribute them later?
Sure.
Okay, that would be lovely. All right, thank you so much for the webinar. It was really, really informative and I think very valuable for our listeners.